webinar on screening mammogram in women in their 40s. We are pleasure to have Dr. Stephanie Morgan, who is a physician at Charlotte Radiology. I'm going to give a couple more minutes before I start. I know we are at 12:31, so I'm going to get maybe 2 more minutes, and then we'll go into an official introduction, and we'll start the program. Want to let everyone know that we will have a question and answer session after the information presented. And if you're just needing to provide information, you can also put it in your chat box, and I will read that to Dr. Morgan. So hold on, and we'll start in 2 minutes. Thank you. Well, it's 12:33. We're 3 minutes into our session, so we'll begin. For those who have recently joined, my name is Travis Roseborough, and I'm acting physician liaison for Charlotte Radiology. Today is indeed my pleasure to present a webinar that we host monthly, and this one is on mammography. I am your physician liaison, and I have the pleasure of introducing an astute physician that works with Charlotte Radiology. Dr. Stephanie Morgan is a board certified radiologist with Charlotte Radiology Breast Center. She completed her medical degree at the Medical University of South Carolina in Charleston, South Carolina. Oh, love Charleston. And her residency at Emory University in Atlanta, Georgia. Dr. Morgan is subspecialized in breast imaging and mammography, having completed her fellowship at Emory University's Winship Cancer Institute. Without any further ado, please join me in welcoming Dr. Morgan. Dr. Morgan.
Good afternoon, everyone, and thank you so much for your time today as we discuss this important issue of screening mammography in women in their 40s. This idea of screening women in their 40s has come under scrutiny in the last several years, and I'm here to make the case of why women should be regularly screened in their 40s. So we'll go on ahead and start. So where we are today, breast cancer remains the most common non-skin related malignancy. Breast cancer is the second leading cause of cancer death among women in the U.S., only behind lung cancer. In 2020, they estimate that 276,480 new cases of invasive breast cancer will be diagnosed. That's 1 in 8 women, along with an additional 48,530 new cases of non-invasive breast cancers, DCIS. More than 40,000 women will still pass away from this disease, unfortunately. 85% of women diagnosed with breast cancer have no family history, and only 5 to 10% of the breast cancers that we see can be linked to a known genetic mutation, most commonly the BRCA1 or 2 gene. There are several known risk factors for developing breast cancer, but the 2 most significant is sex, so being a woman, and age. your risk increases with every year that you're alive. Breast cancer in young women, it's estimated that 12,000 cases of breast cancer occur each year in women under 40 years old. Most people don't even think about young women getting breast cancer, but unfortunately, we do see women in their 20s and 30s getting breast cancer. 26,393 cases of breast cancer each year in women under 45 years old. Breast cancer is the most common form of cancer diagnosed in a pregnant woman or a woman who's recently given birth, and it occurs in about 1 in every 3,000 pregnancies. More aggressive cancers tend to occur in younger women, and those are generally harder to treat. Now to turn to breast cancer in women in their 40s. Breast cancer incidences substantially increase around the age of 40. For example, incidence rates for ages 40 to 44 is twice that than for women 35 to 39 years old. So something happens at 40 years old that doubles your risk. Whereas you compare that to recommendations starting at 50 for screening mammogram, and there's really no identifiable significant change in incidences at 50 years old. So 1 in 6 breast cancers occur in women in their 40s, and the greatest number of years of life lost are to women in their 40s. Regular annual screening mammography beginning at 40 years old decreases mortality from breast cancer by almost 40%, which is astounding numbers to think that just getting a mammogram can decrease that mortality that much. Before widespread screening really began in the 90s, the U.S. Breast cancer death rate had basically remained unchanged for 50 years. And then all of a sudden, as screening mammography became more widespread, we saw this dramatic decrease. Annual screening beginning at age 40 saves approximately 6,500 women's lives in the U.S. per year, more than if you began screening mammogram at 50 years old and doing it every other year. So just that alone, saving that 6,500 women's lives should be enough to motivate people to recommend annual mammography beginning at 40 years old. 40% of all the years of life saved by mammography is among women in their 40s. So just a quick history of the screening mammography. It actually began over 100 years ago, where they would get mastectomy specimens and they would x-ray them to see could they even see cancers, and they could. And then it took a couple of decades before they were able to image the breast in living patients and not just surgical specimens. And then they started doing controlled trials and found out that yes, there is going to be an impact on mortality with screening mammograms. And so then they went on to develop the first screen film mammography system in 73. More studies took place, and finally in 76, the American Cancer Society recommended that mammograms should be used as a screening tool. And then in 1986, the American Cancer Society and the American College of Radiology developed breast screening accreditation program for radiologists and technologists. And then in 92, the government got involved with the Mammography Quality Standards Act, which is known as MQSA. Some of you may have heard of that. It's actually very strict standards that we have to adhere to nationwide for not only the breast center and the quality of the imaging, but also the quality of the interpretation of the images by the radiologist. So it's very important that, you know, patients go to these accredited breast centers that are tightly regulated, because you know they're going to get the best care possible. This in turn led to BIRADS, or the Breast Imaging Reporting and Data System, which is a really great way that we can report what we're thinking in a very concise, using the same lexicon. It's not reporting that's all over the place that people don't really know what we're thinking. So that was a really great way to standardize reporting in the breast world. And then in 2000, the FDA approved the first digital mammo unit. And then finally, in 2011, where we are today, 3D units came on the market. So here's a graph, the effect of on breast cancer incidence. So you'll see the chart up here that shows in the 70s and early 80s, not really much use of screening mammograms. And as we go into the mid to late 80s, the 90s, and into the 2000s, we have much more widespread use of screening mammogram. When we got up to here about 65%, which is where we are today. And then you can see that coincides, same time period down here. And this is early stage cancer detection and late stage cancer detection. And as you can see, as there's an uptick in screening mammography, there's also an uptick in early stage cancer diagnosis. Not a huge change in late stage diagnosis, but screening mammogram isn't for that late stage. Screening mammogram, we want to catch it early when it's still treatable. And this is compared to a background of women who wouldn't really have exposure to screening mammogram, which is women younger than 40 years old, which they really did not show any change in incidence in early or late stage, which would make sense because they're not offered to screen regularly like women 40 and older. Here's another chart that shows, again, as I had said earlier, that mortality was basically a flat line for the decades leading up to the onset of widespread screening mammography, which would be the late 80s, 90s, and into the 2000s. So you can see that here, that mortality was basically a flat line, and then it decreased sharply in the 90s and 2000s. And then you can also see where it says up here, the incidence of invasive cancer, which is this top line here, same as the last chart, shows a sharp increase. And that coincides with the decrease in mortality. And then this bottom line with the triangles is showing the incidence of ductal carcinoma in situ. Screening mammography beginning at age 40 by the numbers. Averaged over the 6 cancer intervention and surveillance modeling network models of benefit, screening mammography shows greatest benefit. Again, that's close to 40%, 39.6% mortality reduction from annual screening of women ages 40 to 84 years old. This screening regimen of annual screening, 40 to 84 years old, saves 71% more lives than the current U.S. Preventative Task Force recommendation of biannual screening for women 50 to 74 years old. And that only had a 23.2 mortality reduction as opposed to 39.6 mortality reduction. For U.S. women currently 30 to 39 years old, so all women who fall in that 10-year demographic, annual screening mammography from ages 40 to 84 would save almost 100,000 more lives than the task force recommendations. And if we only had 65% compliance rate, which is about where we are right now, it would still be about 65,000 more lives. So that's a huge number. That's a lot of young women that would die if we change to the task force recommendations. Mortality reduction, again, this just compares that. It's a chart to show what I just went over, where the top line up here, this is annual screening 40 to 84, showing the highest reduction in mortality. And then these are just different screening recommendations, biennial, 40 to 84, 50 to 84, the current task force recommendations, 50 to 74, and so on and so forth. But clearly, this is the largest benefit of our current recommendations. This is a histogram that basically shows the death by age, so unlikely breast cancer, not breast cancer, likely breast cancer, and breast cancer. This demonstrates nicely. This red and orange is skewed much more towards the younger population as opposed to our older population. What does this mean? That women who get breast cancer younger, again, have more aggressive cancers that are harder to treat. So they're going to be more likely to die from the disease if it's not caught early. And this histogram showed that the median age of 49 years old was the age where most women would die from the disease, whereas women who didn't die from the disease, breast cancer, they were diagnosed later, like 72 years old, they tended to die of other causes. So this highlights why it's so important to find these cancers in these younger women as early as possible, so they can be treated as early as possible. This is a nice pie chart that shows how important screening is. So in age 40 to 49 years, this box over here to the left, this light blue part of the pie chart shows that these are women who were unscreened. So the majority of women who died from breast cancer, 70%, were unscreened in this 10-year group. And that's only about 20% of the women who were not being screened. So it's you can tell how much of a difference that if you're not screened, you're going to be much more likely to die from breast cancer. And that's what this pie chart shows nicely. People talk about what are the harms, why wouldn't you get a screening mammogram? And this would be, if you were to average the risk or the harms of screen over everybody in the population getting a screening mammogram. So a recall would happen once every 12 years. And this has been studied, does this produce so much anxiety that women report long-term effects to their health? And what we found is that, yes, there is a temporary spike in anxiety as they get their call back and they get worked up, but there's no long-term repercussions to that. And even women who have experienced a false positive exam still support screening and are in fact relieved that everything is fine. So that is, as a woman, I find it a little offensive when you read in reports that women get too hysterical about being a callback. I think women can handle that just fine. They would rather know that they're, having the best care taken of their breast than worry about the mental and emotional aspect of that. The next harm would be a negative biopsy every 149 years, a missed breast cancer once every 1,000 years, and a fatal radiation-induced breast cancer once every 76,000 to 97,000 years. So incredibly, incredibly rare when people worry about radiation exposure to the breast. We are so tightly regulated by the government, and this is so well studied that it's a very safe exam for women to undergo. Another thing that people talk about is overdiagnosis. Overdiagnosis is the detection of a breast cancer at screening that would not have become clinically apparent in the patient's lifetime by usual care. Now that contrasts to overtreatment, which refers to therapies for breast cancer that may not be needed and therefore expose patients to adverse effects without reasonable expectation of benefit. The problem is when people talk about these is we just don't really know in our collective scientific knowledge, which cancers prospectively may be overdiagnosed. We just can't tell this radiographically or pathologically at this time. And it's a really difficult measure because very few women, when you tell them they have cancer, say, okay, well, I'm fine just not doing anything and we can see what happens. And I think most people would say if their mom or their sister or their friend were diagnosed with breast cancer, who's going to say, well, let's just leave it in your breast and we'll see if this is one that's going to turn bad or if this would be a good one and never bother you. So it's a really hard thing to measure, overdiagnosis and overtreatment. So plain and simple, we simply just do not know which cancers will advance to become lethal and which ones will not. Every major American medical organization with expertise in breast cancer care agree that starting annual screening mammography at 40 years old saves the most lives. Even the U.S. Preventive Task Force recognizes that starting annual mammography at 40 years old does in fact save the most lives. So, and that's a list there that you can see. We're going to go through a couple of cases now that I think is important and highlights why getting screening mammography in your 40s is important. This is a 46-year-old woman with a new palpable lump in the right breast. She was able to feel it. The image over here, this is her oblique image of her right breast from 2 years prior. This is the current. The BB indicates the area that she's feeling, and you can see there's a new mass that's up here in the posterior part of the right breast. Same thing, this is her exaggerated CC from 2 years ago, and the current, which shows the new mass. Of course, she went on for ultrasound, and you can see this very ugly looking, irregular, hypoechoic solid mass, 2.5 centimeters. We went on to give her a BI-RADS 5, which is highly suggestive of malignancy, and recommended a needle core biopsy. Unfortunately, the patient did not listen to our recommendations and did not follow up for the biopsy when we recommended it. Instead, she returned several months later, and during that time, the mass went from 2.5 centimeters to 7 centimeters, and this is just over a couple months. And the biopsy results returned as a triple negative breast cancer. This was her preoperative breast MRI. And I apologize, the image is kind of grainy, but I think it highlights just how impressive this tumor is. This is her breast mass here, and you can see the tumor is taking up about 30 to 40% of her entire breast. So quickly about triple negative breast cancer. It's a heterogeneous subset of breast cancers, but it's basically ER, PR, HER2 negative. So it doesn't express any of the hormone receptors. It represents about 15% of breast cancers. It does tend to occur in younger women and are typically aggressive and more high-grade tumors. The population most at risk for triple negative breast cancers are premenopausal African-American women. The other risk factors include a history of little to no breastfeeding and patients with a high BMI or a high waist to hip ratio. They do tend to have a poor clinical outcome because of the aggressive nature of the tumor, and there's less treatment options available. Again, they represent a heterogeneous group, but most will be invasive ductal carcinomas. And they do have a high incidence of visceral metastasis, including brain metastasis at a higher rate, and especially aggressive visceral and soft tissue recurrence. So that's just something to keep in mind as far as the metastatic picture of this tumor. This woman did go on to get neoadjuvant chemotherapy and ended up with a mastectomy of that right breast. She actually came in for screening recently and seems to be doing fairly well, which is great for her. So I hope she continues to do well. Here's another interesting case of a 48-year-old asymptomatic patient coming in for routine screening mammogram. Here we have the left CC and the left oblique images. It's a little bit difficult to see, but where the red arrows are pointing, there's two questionable areas of architectural distortion. Maybe a little bit better to appreciate. These are the spot compression images. I have them circled, a little bit easier to see those two areas. The right breast also demonstrated a new area of architectural distortion, which you can see a little bit better with the spot compression images. So this patient went on to have bilateral breast ultrasound, and she's got these 3 separate masses that all look ugly. They have irregular margins, they're hypoechoic, they have shadowing, so they're all highly suggestive that she's got 3 malignancies. So she went on to have ultrasound needle core biopsies of all 3 sites. And interestingly, they were different cancers. So one was an invasive ductal carcinoma with ADH. Another one was invasive mammary carcinoma with ductal and lobular features with LCIS. And then the last one was an invasive lobular carcinoma with LCIS. So here's a 48-year-old asymptomatic patient with 3 different breast cancers in her breast, and she had no idea. So again, I think that highlights the importance of screening these women in their 40s. They're going to have the more aggressive tumors. We need to catch those as quickly and as early as possible to give them the best outcome that we can. So are there any questions out there?
Hey, Dr. Morgan, this is Travis again. We do have a question on the answer board that says, is there any data on WHR and age relative rather.
Is that, what is the WHR? Is that hormone replacement, or what does that stand for? Oh, waist to hip ratio. Okay. And can you repeat the question then? Travis, can you repeat the question?
Yes, can you hear me? Yes,
Yeah.
Can you hear me? Is there any data on weight to hip ratio and age?
As far as, I mean, we know that, okay, any relation between hip to waist ratio and age. Well, we know that with increasing age, breast cancer risk goes up. And we know that with BMI in general, just the increased estrogen is going to increase your risk of breast cancer. Now, as far as there a more tight relationship between age and hip to waist or waist to hip ratio, I'm not aware of one of there being a stronger relationship, other than we know that age is a risk factor, increased BMI, and the associated elevated estrogen that goes along with that. And then specifically with the triple negative, that we know that having that central obesity, but I don't know, I'm not aware of anything beyond that.
Okay, thank you on that. Dr. Morgan, we have another question.
Okay.
You spoke about those ladies that are younger having more aggressive cancers. When providers see women who are under the age of 40 and they want to have mammograms, what is your suggestion, and how frequently thereafter that baseline?
So if they're of average risk, so meaning they don't really have any strong family history, there's no history of chest mantle radiation or anything else that would put them at increased risk, the general guideline is, again, starting at 40. A lot of providers do like to get a baseline at 35, and I think that's completely reasonable, and then sending them back again at 40 if that is, everything looks good at 35. We will do mammogram on women who are under 40 if they come in symptomatic or there clinically is a problem. So if they're between the ages of 30 and 40 and the referring physician or provider feels something, or there's nipple discharge, or the patient has a problem, we do start with mammogram and then go to ultrasound as needed. We don't typically start with mammogram in a woman who's under 30. Under 30, we usually start with ultrasound, just because typically their breast tissue is so dense, the yield with mammogram is lower. So we'll start with ultrasound and then only do mammogram if we think that it would be helpful at that point. So if you want to screen younger than 40 and they're of average risk, you could start with a baseline at 35, only if you want to. It's not necessary. We do recommend starting at 40. If they have a family history of breast cancer, of course, that recommendation changes. It's 10 years before the age of diagnosis of their first degree relative. So if their mother had breast cancer at 42, then they would need to start screening at 32. Or if their mother had breast cancer at 40, then they would have to start screening at 30, or their sister, and so on. So, that changes when it's a high risk population. So do keep that in mind. And of course, if they had a family member, mother, sister with it in their 30s, then we start talking about MRIs in their 20s until they get 30, and then they start screening mammograms. So it gets a little complicated, but that's how we would proceed with that age group.
Great. Thank you, Doc. We have another question. It states, how important is breast density estimation in age 40 to 45 years?
So we do include breast density in all of our screening reports. As you know, we go fatty, scattered, heterogeneously dense, and extremely dense. And you can have a small bump in your risk factor for breast cancer with elevated breast tissue density. So the heterogeneously dense, extremely dense, but it's not enough to make you high risk. So it's something that we like to tell women about, so that if they wanted to get supplemental screening, for example, abbreviated breast MRI or screening breast ultrasound, which are things that we offer, they could do that, but they don't have to. Screening mammogram is still the gold standard, no matter what your breast tissue density is, especially since we do 3D mammography on everybody. It's a very good exam. But when your breast tissue density goes up, it is a more difficult exam to read. And that's why we like to tell patients, and if they want supplemental screening, they can do that, but they don't have to. But it is a small increased risk in breast cancer, but not enough to make you a high risk patient just with that alone.
Great, great. Any other questions? Okay, there's another question, Doc. When you say risk is, excuse me, when you say risk, is it what is estimated by the risk estimation models?
So there's a lot of different risk models out there. Tara-Cusack is one of the more common ones that are used. But yes, that is taken into account in those risk models, is what your breast tissue density is. Mm-hmm.
Okay. Any other questions? They're coming in, Doc.
That's great.
Have a question concerning mammograms and COVID. With a lot of the delays, do you think it will impact the diagnosis of cancer?
Absolutely. Unfortunately, we expect to see, and I have personally seen this in my clinic, women who either entirely skipped a year of screening or were symptomatic and just put it off because they didn't want to come in during, any surges of COVID, and they were feeling a lump. And so we have unfortunately seen some delayed diagnoses of cancers that would have been caught sooner had these patients come in for their regular screening or come in when they were initially symptomatic. And that's, the nature of the beast. That's why we want people to come in every single year, because even every other year, we're going to have those people that are going to present on those off years that if we had caught them during that off year, it goes from being a treatable disease to an untreatable disease that next year, where you're living with a potentially metastatic disease at that point to a curable disease if we had caught it in that middle year when it was caught by screening mammogram. So we still, we want people to come in every year. We don't want them to miss it. And, I understand the fear associated with that, but we've done an excellent job of, cleaning regimens in our breast clinics, wearing masks. Everything is very well done in our clinics. Your patients should feel very safe when they come in, that they're not going to be exposed, they're going to be well cared for. So they should put their health of their breast, as a top priority and make sure they come in and take care of that.
Okay, well, thank you. We have another question. It says, do BACs, breast alteration, calcification, are related patient age?
Are we referring to
Arterial calcification are related to patient age?
Yes. So so we do see arterial calcifications quite frequently in women. Typically, if the woman's older than 65 years old, it's not something that we usually remark on because most people get arterial calcifications as they age. When we start seeing heavy calcifications in women in their 40s and 50s, many of us will remark on it because, that's unusual. And it may be a clinical finding that you're already aware of. Maybe they have diabetes or, known coronary artery disease or something like that. But we will remark on it in younger women because it's not normal to see heavy artery calcifications in the breast in women who are under 60.
Great. Thanks, Doc. We're still answering questions. I know that we're 5 minutes over, but these are some great questions. If anybody else, anything else, please send them in. And if you think of them at a later date, please feel free to email us. We appreciate it, and we have a lot of fun going over these things because it makes us more understanding to what we're dealing with. Let's see. I think that's it, Doc. And with that, at 1:05, I think we'll sign off. I thank everyone for participating. Dr. Morgan, thanks again for hopping on and giving us all of your information. If you anything else to add, we'll sign off.
Nope. Thanks so much, guys. I appreciate y'all showing up.
All right. Thank you, Dr. Morgan.